Imagine for a moment you're responsible for making these huge healthcare decisions, where the money goes, which treatments get the green light, how you look after different kinds of patients. You've got piles of data, really rich descriptions of people's health, what we call health profiles. But here's the thing. For those big calls, you don't always need the full painting. You need a single number you can compare. How do you get from that detailed description to one simple score everyone understands? That's a massive challenge in health economics. And it's exactly where this idea of mapping fits in. Today, we're doing a deep dive into a really fascinating study. It looked very carefully at different ways to convert health quality of life data from one format, the SF-12, that's a common health profile, into another, the EQ-5D. And the EQ-5D gives you that single number that's just essential for economic evaluations. This isn't just number crunching. It's really about how we value health, how we decide where resources go, and making sure our assessments are actually accurate, especially, for diverse groups of patients. Understanding these methods, it's kind of a shortcut to seeing the hidden complexities behind health policy. So, yeah, let's unpack this. Let's see what this research tells us about getting the right numbers for better health decisions.
It's a great way to frame it because it really gets at that core tension. You've got these two incredibly useful tools that SF-12 gives you, as you said, this rich, detailed picture of someone's health across different areas, paints that portrait. And then there's the EQ-5D, which boils it down to that single quantifiable number, that utility weight between 0 and 1. And that's what economists absolutely need.
Yeah.
The challenge, like you said, is making them speak the same language accurately.
Exactly. Different tools, different jobs, both vital. So let's maybe dig into why that single number is so critical. You mentioned cost utility analyses, basically figuring out if a new treatment is worth the cost. For that, analysts need that single summary measure of health-related quality of life, HR-QOL, and crucially, it has to be utility weighted. This utility weight, it's a number, usually 0 to 1, right? 0 being worse than death, 1 being perfect health. And it reflects how society values a particular health state.
That's right. It's a standard way to compare the health benefits of totally different interventions.
But the snag is, clinical studies often just give you the detailed profiles, like the SF-12. They describe health, but they don't give you that all-important utility score needed for the economic side.
Precisely. And let's get a bit more specific on these two measures. The SF-12, the short form 12, it's a generic health status profile. 12 questions, a couple of response options for each, covering 8 areas, things like physical function, pain, mental health. From those answers, you calculate 2 main scores, a physical component summary, PCS-12, and a mental component summary, MCS-12. Higher scores mean better health. It's the detailed picture.
Okay, that's the SF-12 portrait, and the EQ-5D is what we're trying to map onto.
Right. The EQ-5D is a generic index measure, much shorter. Just 5 questions. Mobility, self-care, usual activities, pain or discomfort, and anxiety or depression. And only 3 levels for each. No problems, some problems, extreme problems, simple. But this system defines 243 possible health states. And crucially, each state gets assigned that single number, that utility weight, based on what people in society prefer. In this study, they used U.S. preferences from back in 2002. That's the single comparable number economists need.
So if your study used SF-12, but the economists need that EQ-5D number, the standard practice is to try and map or convert the SF-12 data into the EQ-5D format. But the big issue, and what this study really tackled, is that nobody really agrees on the best way to do that conversion. There's no single magic formula.
Exactly. Which is why this study was so important. They had this huge data set, nearly 20,000 adults from the Medical Expenditure Panel Survey, MEPS, from 2003. And the key thing, everyone in that data set had filled out both the EQ-5D and the SF-12.
So they had the real EQ-5D answers to compare against.
Precisely. It allowed them to directly compare how well different mapping techniques performed against the actual observed EQ-5D scores. It was like having the answer key while grading the matching attempts.
Okay, so problem defined, answer key. Ready? The researchers then brought out their statistical toolbox, right, to see which tools could best build that bridge between the SF-12 description and the EQ-5D number. They lined up 4 main techniques, each with a different approach. And this is where it gets really interesting because, the most common tools aren't always the best fit for the job.
Indeed. First up was ordinary least squares regression, OLS. It's kind of the default, the workhorse in statistics. Widely used, straightforward, tries to minimize errors. But the EQ-5D scores have this odd shape. A huge pile of people score 1 perfect health, then a long tail stretching down towards poorer health. OLS assumes things are more normally distributed, like a nice symmetrical bell curve.
Right, so it struggles with that ceiling effect you mentioned, where lots of people hit the maximum score.
Exactly. OLS isn't really built for that kind of distribution. Which leads us to the second method they tried, censored least absolute deviation regression, or CLAIR.
CLIDAD.
Sounds specific.
It is. It was chosen specifically because of that ceiling effect. In this study's data, almost half the people, 47.6%, reported perfect health, a score of 1. That's a massive cluster. CLIDAD is designed to handle this kind of censored data where lots of values pile up at one end. It acknowledges that the score of 1 isn't just another point, it's a boundary. OLS just ignores that.
Okay, that makes sense. Tailoring the tool to the data's shape, what was the third approach?
The third was the multinomial logit model. This one takes a totally different path. Instead of predicting the final EQ-5D score directly, it first predicts the probability of answering no problems, some problems, or extreme problems for each of the 5 EQ-5D questions separately.
Okay, so it predicts the individual answers first. Yeah. Once it predicts those answers, it defines the overall health state and then assigns the utility score for that state. A big plus here is that it avoids the tricky distribution issues of the final EQ-5D score itself. And importantly, you can easily swap in different countries' value sets without redoing the whole model.
That sounds quite elegant, actually, breaking it down. And the fourth method?
The fourth was a two-part model. This one's pretty interesting and less common. It splits the whole estimation process in two. Part 1 models the probability of someone being in perfect health having that EQ-5D score of 1. Part 2 then models the scores for everyone else who isn't in perfect health.
So it explicitly treats those two groups differently.
Exactly. The thinking is that people reporting perfect health might just be fundamentally different from those with any health problems, however minor. So this model tries to capture that difference, that heterogeneity, by analyzing them separately.
Right, that makes intuitive sense too. Okay, so 4 different statistical engines. But they also looked at the fuel, right? How the SF-12 data actually went into these models.
Precisely. These were the model specifications. 2 main ways. First, using the summary scores, the ready-made PCS-12 and MCS-12 scores. That's often easier because those scores are readily available.
The pre-processed version.
Kinda, yeah.
Yeah.
The second way was item-based. This used the answers to the individual 12, or sometimes 11, excluding one general health question, SF-12 questions as separate inputs.
Using the raw ingredients, basically.
Exactly. And that's seen as more theoretically sound because you're not relying on the assumptions baked into how those summary scores were calculated in the first place. You keep more of the original detail. And they deliberately left out things like age or gender to keep the focus purely on comparing the mapping methods themselves.
Okay, that sets the stage perfectly. We have the methods, the data inputs. So what happened? Which method came out on top? Were there any big surprises when they crunched the numbers?
Well, the first major finding was pretty clear-cut, actually. Across all the different techniques using the individual SF-12 items, the raw ingredients consistently performed better than just using the summary scores.
Item-based models won out.
Pretty much across the board, yeah. Based on things like how well the model fit the data, the size of the errors, it just gave more accurate predictions.
That feels right, somehow. More detail in, better results out.
It makes theoretical sense, too. You're avoiding the assumptions built into the summary scores and keeping the richness of the original SF-12 data. But here's where it got really surprising. Remember OLS? The simple, standard regression. Despite its known issues with the EQ-5D distribution, it turned out to be remarkably accurate at the overall population level. For the whole group of nearly 20,000 people, the average EQ-5D score predicted by the OLS model was basically identical to the actual average score they observed.
Wow. Okay, that is surprising. The basic tool did the best job on average.
On average, yes. And it also had the lowest proportion of really big errors, so when it was wrong, it wasn't usually wildly wrong.
Yeah, there has to be a catch, right?
There's a major catch. While OLS looked great for the average across everyone, its accuracy just fell apart when they looked specifically at older people and people with poorer health.
So the average hid significant problems for specific subgroups.
Exactly. And those are often the very groups you're most interested in for healthcare decisions. So good on average, but potentially very misleading for vulnerable populations.
That's such a critical point. A method might look good on paper for the whole population, but it fails when you need it most for specific patient groups. So what about the other, more sophisticated methods? CLIDAD and the 2-part model, did they do better for those subgroups?
They did, relatively speaking. Both CLIDAD and the 2-part models generally had smaller errors when looking at individual predictions. Their mean absolute error, or MAE, was lower.
Meaning they were, on average, closer to the true score for each person than OLS was.
Yes, exactly. Even if their overall group average wasn't always spot on like OLS, they were generally more precise at that individual level. And the two-part model particularly stood out. It consistently performed better than OLS in those subgroup analyses. It gave much closer estimates for older people and those in poorer health.
So separating out the perfect health group really did seem to help capture the reality for less healthy people.
It suggests that yes,
Yeah.
acknowledging that fundamental difference that heterogeneity sees to improve prediction accuracy, especially where it matters most.
Okay. And the multinomial logic,
Yeah.
the one that predicted answers dimension by dimension, how did that fare?
Despite its theoretical appeal, it didn't actually perform better than OLS in predicting the overall mean score. And, worryingly, it tended to have larger errors when it was wrong. So its mistakes were bigger, making it less reliable overall in this particular comparison. And if we just pull back for a second, think about the implications. The choice of mapping method isn't just some technical footnote. It directly influences health economic evaluations. If your chosen method underestimates the quality of life for, say, older patients with chronic conditions, that could lead to undervaluing treatments that benefit them. Resource allocation decisions could be skewed.
Yeah, that really brings it home. It's not just stats. It's about potentially life-altering decisions based on these numbers. So after meticulously comparing all these approaches, what was the big final takeaway? What should someone doing health research or policy take from this study?
Well, the single biggest takeaway, and it's a really important one, is probably this. None of the mapping methods they looked at are really suitable for accurately estimating health status at the individual level.
None of them. Not even the best ones.
Not with enough precision, no. The errors, the difference between the predicted score and the actual score, just got too large, especially when looking at those older and less healthy subgroups. So you absolutely cannot use these mapping techniques to reliably say what one specific person's EQ-5D score would be based on their SF-12 answers. The predictions just aren't accurate enough for that.
Okay, that's a huge caveat. No individual predictions. What about for group averages? Can we use them for that, maybe for specific patient populations?
Even there, the study urges caution. While some methods get closer on average, significant discrepancies were still found between the mapped scores and the actual scores, particularly in those less healthy groups. It's a bit like using a blurry photo. You might get the general gist, but the important details, especially for specific parts of the picture, are lost.
So if mapping isn't reliable enough, especially for the groups we often care most about, what's the solution?
The study's ultimate recommendation is pretty straightforward. If you need that preference-based single index score like the EQ-5D for your economic evaluation, then you should include the EQ-5D directly in your clinical study right from the start. Don't rely on mapping later. Just measure the thing you actually need.
Collect the right data up front. Avoid the whole mapping headache and its uncertainties.
Exactly. It avoids all the complexity, the assumptions, the inevitable errors that come with trying to translate between these different measurement systems.
That makes a lot of sense. But the way this study was done, the methodology of comparing these mapping techniques, that itself seems valuable, right? Could it be used elsewhere?
Oh, absolutely. The framework they used, taking a data set with both measures, testing different algorithms, different model specifications, checking against the real scores, looking at subgroups, that's a really robust way to evaluate any mapping exercise. You could definitely use the same approach to compare mapping methods for, say, the longer SF-36 or other profile measures people might want to convert to an index.
And they were upfront about their own study's limitations, too.
Yes, definitely. They mentioned their data wasn't weighted to be nationally representative of the U.S. population. They also did their validation within the same data set they built the models on, rather than testing on a completely fresh external data set, which is always the gold standard.
Okay.
And they noted some small potential time lags between when people filled out the SF-12 and EQ-5D, which could introduce a tiny bit of noise. Good scientific practice to acknowledge those things. But it really throws down a gauntlet, doesn't it? In this era where we're aiming for personalized medicine, precision healthcare, how good are our fundamental measurement tools? If even our best mapping techniques struggle, especially for vulnerable groups, how do we ensure our data is truly informing equitable decisions and not accidentally baking in biases because of measurement limitations?
That's a really powerful question to reflect on. So let's recap. We've dived deep into this challenge of converting detailed health profiles, like the SF-12, into that single EQ-5D index number needed for economics. We saw that while a simple method like OLS might look okay on average for a whole population, it can fail badly when you zoom in on specific groups like older or sicker patients.
Hmm.
More complex methods, like the two-part model, showed some promise, particularly for those subgroups, by treating perfect health as distinct.
Right, acknowledging that heterogeneity seemed key.
But the massive takeaway is that none of these mapping methods are really precise enough for individual level assessment. The errors are just too large.
Which leads to the core recommendation. Measure it directly. If you need the EQ-5D score, include the EQ-5D in your study.
So for you listening, this really underscores how important it is to ask critical questions whenever you see health data being used, especially for economic evaluations. Where did this number come from? Was it measured directly, or was it mapped from something else? And if it was mapped, what were the known limitations of that process? Was it likely to be less accurate for certain groups?
Asking those questions is crucial.
And it leaves us with a final thought to chew on. We're seeing incredible advances in AI, machine learning, data science. How might these future technologies change the game here? Could they potentially give us much more accurate ways to map complex health data? Or perhaps, could they even make mapping obsolete by allowing us to capture and use much richer, more direct measures of health outcomes right from the start? What might a truly personalized health utility score even look like in the future? And how far away are we from being able to calculate one reliably?